everyone! Maria Grace Tablada here, a student of Cebu Doctors University taking up International Studies, American Literature. So in this video, I am going to present my final presentation of which I tackle a research question, which is how has the American healthcare system reliance on private insurance and market forces influenced social inequalities and access to healthcare among different social groups? Probably you will ask me why I choose this topic. I choose this topic because I am deeply concerned about the impact of the American healthcare system's reliance on private insurance and market forces. Now, let me bring to you the essence of this question. First, let me run through to our agenda in this video. Here are the brief explanations for each agenda item in this presentation. Of course, the introduction. This slide will provide an overview of the unique market-based nature of the U.S. healthcare system and its reliance on private insurance companies. It will highlight why examining inequalities and access barriers across different social groups is an important issue. In research question slide, this slide will clearly lay out the key questions the researchers or me to investigate, such as how factors like income, race, employment status, and location impact affordable healthcare access and outcomes. In insurance coverage gaps, this section represents data and statistics on the millions of Americans who lack adequate health insurance coverage, with a focus on disproportionately high uninsured rates among low-income, minority, and other disadvantaged populations. Healthcare costs. It will examine the rapidly rising cost of healthcare premiums, deductibles, and out-of-pocket expenses that create significant financial barriers, especially for economically disadvantaged groups. In geographic disparities, these will look at how market dynamics lead to uneven access and provider shortages across different regions, such as rural areas, low-income urban neighborhoods, and states with differing policy decisions. In racial or ethnic inequalities, despite efforts to reduce disparities, this section will show that systematic inequities persist, with minority groups facing higher uninsured rates, lower quality care, and poorer health outcomes influenced by social determinants. In market failures slide, it will critique how a profit-driven private insurance system has failed to ensure equitable, affordable access through practices like risk screening, lack of preventative care incentives, and prioritizing profits over patients' needs. And in policy consideration, this will outline potential policy solutions to address systematic inequalities, such as expanding public insurance, stronger regulations, and shifting towards a more universal, equitable healthcare model. And of course, the last is the conclusion, which will summarize how the market-based U.S. healthcare system perpetuates embedded inequalities across income, race, geography, and other socioeconomic factors, suggesting fundamental reforms may be required. So, without further ado, let's get this started. On the research question, how has the American healthcare system's reliance on private insurance and market forces influenced social inequalities and access to healthcare among different social groups? At first, you may think that this question is too long, and you may question this gap. So, one gap that is already evident is the lack of universal, equitable access to healthcare for all social groups in the United States. The U.S. healthcare system is unique in its heavy reliance on private insurance companies and free market competition. This market-based model has influence on healthcare access and outcomes across different social groups in significant ways. Most Americans under 65 obtain healthcare insurance through private employers or individual markets. Unlike other developed nations with universal public healthcare systems, the U.S. relies heavily on private insurance. Around 67% of non-elderly Americans get health coverage through employer-sponsored group plans. Another 7% purchase private individual market plans. This employer-based system ties healthcare access to job status and private insurance markets. Healthcare is treated as commodity with costs determined by the market. The US healthcare system operates much like other consumer markets with pricing driven by supply and demand dynamics. Treatment options and also cost of services, drugs, and insurance premiums are dictated largely by market forces rather than regulated pricing. This contrasts with single payer system where governments control healthcare pricing and delivery. And lastly, profit motives and business factors impact insurance coverage decisions. Private insurers aim to manage risk pool and control costs to maximize profitability for shareholders. They carefully design provider networks, premium prices, deductible levels, and coverage limit accordingly. Coverage determination process consider financial factors over just clinical needs and evidence. Healthy individuals are more desirable customers from an insurer business perspective. Just as what Sir Neil said na they prefer much more sa kapag wala kay generational disease or way existing sakit daan. So, the research question. In this research question, has within research question. So here are my another question for this question. The first one is how do factors like income, employment status, race or ethnicity, and geographic location affect access to affordable health insurance and care? The second question is what inequalities exist in healthcare utilizations, costs, and outcome across different socioeconomic and demographic groups. Lastly, how do market forces like provider competitions, insurance plan design, and cost-sharing policies influence these parties? So, along throughout this video, we may answer this question or we may not. But most importantly, we raise another gap for the future students. Oops. So the insurance coverage gaps. Millions of Americans lack affordable health insurance due to systematic barriers. Lack of insurance coverage is a major barrier with 31.6 million Americans uninsured in 2020. In 2020, 31.6 million or the 9.7% people of all ages were uninsured at the time of the interview. This includes 31.2 million, which is 11.5% people under 65. Among children, 3.7 million, which is 5% of population, were uninsured, and among working age adults, age 18 to 64, is 27.5 million, which is 13.9% were uninsured. Among people under age 65, 64.3% were covered by private health insurance, including 56.6% with employment-based coverage and 6.7% with directly purchased coverage. Moreover, 4% were covered by exchange-based coverage, a type of directly purchased coverage among people under 65. About 2 in 5 children and 1 in 5 adults were covered by public health insurance coverage, mainly by Medicare and Children's Health Insurance Program or the CHIP. Among adults aged 65 and over, the percentage who were covered by private health insurance with or without Medicare and Medicare Advantage, traditional Medicare only varied by age, family income level, education level, and race and Hispanic region. Higher uninsured rates for low-income, minority, and immigrant groups is another barrier of uninsured Americans. As we can see on this graph, Hispanic are more than one-third of all Hispanics under age 65 are uninsured. American Indians and Alaska Natives are almost one-third of all American Indians and Alaska Natives are uninsured, a rate almost as high as that for the Hispanics. African Americans, non-Hispanic African Americans are almost twice as likely as non-Hispanic whites to be uninsured. Asian Americans and Pacific Islanders, there are disproportionately high uninsured rates among some ethnic groups collectively described as Asian American and Pacific Islander, reflecting the particular groups in distinctive social, economic, and demographic characteristics and members' status as immigrants, refugees, or US-born citizens. Racial and ethnic disparities kay another quantity ni siya kanang like barriers ano kay non-Hispanic African Americans are twice as likely and Hispanics 3 times as likely as non-Hispanic whites to be uninsured, reflecting disparities in employment-based coverage and income levels within each group. Makita dira sa graph kay the Hispanic population is the one-third of kanang under 65 that are uninsured, with declining rates of employment-based coverage and lower rates of public insurance contributing to the high uninsured rate. So, kanang other general population under 65 is apil dira ang immigrants, which are more likely to be uninsured, with disparities persisting among those with income below 200% of the poverty line. Fewer immigrants have employer-sponsored health insurance, and they are less likely to have public coverage like Medicaid, leading to higher uninsured rates compared to native-born citizens. Also, low-income immigrants are less likely to have public coverage, employer-sponsored coverage, or other private coverage, contributing to the insurance gap between low-income immigrants and citizens. Immigrants, especially unauthorized immigrants, face challenges in accessing healthcare due to high costs, lack of insurance coverage, usahay dili magkuan ilang language, which we call language barriers, and limited access to primary and preventative services, which results to taas gyud na kuan kanang out-of-pocket costs and reduced utilization of healthcare services among immigrants compared to the citizens of the U.S. So these sources emphasize that systematic factors such as employment-based coverage, income levels, and immigration status contribute to the higher uninsured rates among low-income minority and immigrant groups in the U.S. healthcare system, perpetuating disparities in access to healthcare outcomes. So here is the detailed description for the recent graph that I showed you in the video, which is health insurance for population under 65 by race and ethnicity. Kanang ang kuan pod ang rounding ani kay di jud maabot og 100% because naay uban gi round up na or na uban gi round down. Learn more na about the detailed version. You just pause the video and then you can see the legend here. Okay. The third insurance coverage gap is exacerbated by high premiums, deductibles, and out-of-pocket costs. High out-of-pocket costs, even for those with insurance, prevent many from seeking necessary care, with around 30% of Americans citing high costs of a barrier to treatment. The uninsured are much more likely to report difficulties affording needed medical care and prescription drugs, and are more likely to forgo them due to costs compared to those with Medicaid or private insurance. Underinsurance is also a major issue, with over one-third of low-income adults estimated to be underinsured, spending more than 5% household income on medical care. This leads to deferring or delaying care. High deductible care or health plans are associated with lower healthcare utilization, including for needed preventative services, such as people avoid care to minimize out-of-pocket costs. Rising insurance premiums for employer-sponsored private coverage have eroded wage gains for middle-class Americans, further burdening the household's budgets and reducing disposable income. Medical indebtedness is common among both insured and uninsured Americans and often leads to bankruptcy. Then, in short sentence, The reliance on private market-based healthcare system with high out-of-pocket costs has created significant barriers to accessing healthcare, especially for low-income, minority, and underinsured populations, and existing disparities in healthcare coverage and outcomes. Moving on to our fourth agenda of this video, the healthcare costs. Rising healthcare costs and lack of universal coverage place significant financial burdens, especially on disadvantaged groups. Average premium or family premium for employer-based insurance was $22,221 in 2021. This average annual premium for family coverage through an employer represents a massive financial obligation equal to a significant portion of many households' total income. For low-wage workers, these premiums eat up an even larger percentage of ilang kita o ilang sweldo sa balay, making insurance unaffordable. Premium costs have outpaced inflation and wage growth for over a decade, stretching family budgets. Many employers require high deductibles and employee premium contributions to offset their own costs. A high deductibles and cost sharing deter me from seeking needed care. In addition to premiums or family premiums, most plans have high annual deductibles that must be met before coverage kicks in. Average like $1,669 for single coverage in 2021. These significant out-of-pocket costs may insured individuals, especially those with low incomes, to avoid or delay seeking necessary medical care due to expense. Preventative care and treatment of chronic conditions suffers, leading to poor health outcomes. Naiuban makautang nya mabankrupt kay dili jud maka-impact jud sa low-income families. Even with insurance coverage, the cost of premiums, deductibles, and surprise billing can quickly accumulate into crippling medical debt. In 2020, a research study, an estimated 1 in 8 Americans had medical debt over $250, and 1 in 7 had debts over $2,500. Medical issues are leading cause of personal bankruptcy filing in the U.S. Low-income uninsured individuals face even higher risk of catastrophic medical debt and financial ruin. This debt weighs heavily on disadvantaged groups, impacting their credit, housing, education, and economic mobility, of course. So while healthcare is promoted as privately commodity and insurance is meant to provide risk protection, the current system places immense financial strain on many Americans, with the burden falling disproportionately on disadvantaged socio-economic groups. Kining inequalities kay inhibits access to affordable care and better healthcare outcomes. Next is how is market dynamics lead to geographic disparities in healthcare access across different regions. Provider shortages and care deserts in rural and low-income urban areas. This concentration of healthcare resources is driven by population density and profit incentive for providers. Kanang mga clinic dito sa mga probinsya like barangay clinic are often face significant shortages of doctors, specialists, and healthcare facilities as there as less likely na sila financial incentives for them to open practices in sparsely populated regions. Sa muang barangay is gamay ra jud kaayo ang doktor. So kung mga anak ka, mag-advance yun adto sa cities, sa urban areas. This creates healthcare deserts, where residents must travel distances or go without adequate care. So, kaya na, mo travel jud niyo ka ng diri sa city, kay daghang og doktor, daghang og kanang medical machines, and medicine. Low-income urban neighborhoods frequently lack sufficient hospitals, clinics, and providers compared to wealthier areas of the city. So, half government ang suto, murag gyapon siya og mapaya sa Amerika na murag makulangan gyapon sila hospital, makulangan gyapon sila og kanang clinics, kanang paanakan, kay naman siya sa populated area o naman siya sa low-income na place. This maldistribution of healthcare resources reflects the market's tendency to underserve areas deemed less profitable. So, sa Amerika, may nalang diri kay kung mga poorer areas is mag-provide ang government o kanang clinics. Pero sa Amerika is they treat the healthcare as businessman. They treat it as business. So kung gamay ra tao dito or gamay ra og kanang ka-afford or gamay ra og kanang kita nila dito or profit, dili gid sila mo tukod dito og kan hospital or clinics or di sila magpadala og doktor because kanang magamay ra lang mga profit. Next is narrow insurance networks restricting affordable options. To control costs, insurers construct narrow providers network excluding many doctors or hospitals. Consumers in certain regions may have few or even affordable in network options availability locally. This severely limits the ability to access a network covered care without paying kanang grabe gani in out of network rates. Network breadth and composition varies greatly by geography due to market factors and negotiating leverage. Lastly, state policy decisions in Medicaid expansion and regulation influence these parties. States have flexibility in implementing these or the Affordable Care Act's Medicaid expansion for low-income residents. As of kanang year 2022, 12 states have not expanded Medicaid, leaving millions uninsured or uninsured. State policies regulating insurers, provider rates, health facility oversight, etc. or mga unsa sa dira also impact relative costs and access. This patchwork of state regulations allows geographic inequalities to persist across the country. So while health insurance is national, the fragmented way of healthcare delivery, insurance market, and regulations play out locally across thousands of different geographies directly shapes disparities in cost, availability, and accessibility of services depending sa nagpuyo. Racial or ethnic inequalities in healthcare access and outcomes in the United States. Higher uninsured rates and lower access to affordable coverage for minority groups. Despite efforts like Affordable Care Act, minority populations in the U.S. continue to have disproportionately higher uninsured rates compared to whites. In 2020, over 21% of Hispanics and 10% of Blacks were uninsured versus just 7% of whites. Income and employment disparities contribute, but inequalities persist even after controlling for socioeconomic factors. Minority groups also face greater difficulties affording premiums, deductibles, and out-of-pocket costs even when insured. Limited access to employer-sponsored insurance and under representation in certain occupations exacerbates these coverage gaps. The next is differences in quality of care, preventative services, and healthcare outcomes. Decades of research show minorities receive lower quality healthcare services across numerous indicators, even with similar insurance and medical needs. They are less likely to receive preventative screenings and treatments for chronic illness. Health outcomes like infant mortality, disease rates, and mortality are significant worse among Black, Hispanic, and Native American populations. Issues like provider bias, culture, or language barrier, and distrust in medical system contribute to these disparities. Last one is social determinants and structural racism is as underlying drivers. Racism. At the root cause are long-standing structural systematic inequalities in areas like education, housing, socioeconomic opportunities, and environmental exposures. These social determinants driven by historical racism, discrimination, and disinvestment set the stage for poorer baseline health. Centuries of systemic racism and oppression have created a reality where minority groups face disproportionate economic, environmental, and physiological stressors negatively impacting health. The healthcare system itself reflects and perpetuates these larger societal inequities through its design and distribution of care. Despite policies aimed at expanding insurance access, the unfortunate reality is that deep-rooted racial or ethnic disparities in healthcare persist. Until now, di ba? A result of complex interplay between the healthcare system, social determinants, and larger context systematic racism, historically leaving minorities disadvantaged. This art, isa lang kung makanotice ta sa art, it is showing that there are so many private insurance and market competition, thus resulting in failing to ensure equitable, affordable healthcare access. So, kay dagan man og nagtukod og kanang healthcare insurance or healthcare clinic na mo provide og nga insurance, nagkamahal sad or pataka na sila pamahal kay private man. So, sila rin makabuot og pila lang i-charge. When market competition is promoted as a way to drive efficiency and lower costs, in reality, the profit-driven nature of private insurance breeds opposing incentives to systematically exclude higher-risk groups, underinvestment in preventative care, and prioritize business gains over patients' interests and public health. Unfortunately, tinuod ni siya. Even this sa Philippines, we can feel it this week ng mga private kanang hospital, di ba? This perpetuates disparities and raises overall system costs. Adverse selection, risk pools, and medical underwriting exclude higher risk groups. Insurers aim to construct risk pools with younger, healthier individuals to keep premiums down. So, ang kanang mga insurance is dali ka sila wadawat o kanang mga batanon pa kay mga sakit, kanang walay mga history of diabetes, mga heart attack, high blood pressure, kay para ang ilang premium kay kanang mas dako ang profits gani nila. Medical underwriting allows them to deny coverage or charge higher premiums to higher risk applicants with pre-existing conditions. Adverse selection occurs when mostly sicker people sign up, saddling insurers with skyrocketing costs be offset through higher premiums and exclusions. This dynamic prices out or limits coverage options for those with greater health needs, perpetuating disparities. Market incentivize insurers to avoid overrepresentations of higher risk, costlier enrollees. So moving on to our potential policy solutions to address systematic healthcare inequalities. The first one is expanding public insurance programs and subsidies. And increasing eligibility and funding for government programs like Medicaid and Children's Health Insurance Program, which I mentioned earlier, to cover more low-income individuals and families. Providing larger premium subsidies and cost-sharing assistance through the Affordable Care Act marketplaces. This would make comprehensive health coverage more affordable and accessible for disadvantaged groups or katong mga discrimination sa ilang ethnicity or race. Mura siya public insurance, pero na siya option kung mo take ba siya sa public insurance, nahinay og kang processing, or mukan ba siya sa Medicare, which is buy-in could inject competition and universality into the system. However, expansions face political opposition over costs and rule of government. Transitioning towards a universal, equitable healthcare system. Moving towards a single-payer or other unified public healthcare financing model could detach coverage from employment and delink it from profit motives. Under a universal system, healthcare access becomes a right and equitable provision of comprehensive services as the driving principle rather than market dynamics. By eliminating or heavily regulating the private insurance role, problems like risk pool manipulations are minimized. Payments models shape away from fee-for-service towards global budgets and population-based payments better aligned with public health goals. However, such systemic overhaul would radical political challenging transformation. Each of these policy paths offers with potential for reducing inequalities compared to the status quo, but each also faces economic and political hurdles. Expanding public programs is most incremental regulation is middle ground, while transforming to a universal system require more fundamental disruptive changes to how healthcare is financed and delivered in America. So ang atong conclusion, ang conclusion nako karon is kanang although makabasa mo sa ako ang description na akong i-conclude diri sa kini na research question, but let me add something na wala sa clip because Sir Neil said na I can't reading off based on the slides. Oh, I must kanang put my thoughts into words. So while discussing, I realized that the US healthcare system is set up with its heavy focus on private insurance companies competing for profits. It's up creating and reinforcing major inequalities in which who can get quality, affordable healthcare coverage and treatment. These inequalities follow existing divides in society based on things like how much money people make, their racial or ethnic background, and where they live geographically. Other social and economic disadvantages also play a major role here. Because private insurers are motivated by money or by making money or profit rather than providing affordable care for everyone, they tend to avoid coverage higher risk for more costly groups. It also concentrates services in wealthier areas rather than underserved communities. This market-based model ends up pricing out and limiting healthcare access for those who are already economically disadvantaged, racial or ethnic minorities, rural residents, and other vulnerable populations with greater health needs. While policies have tried to reduce these disparities, they remain deeply entrenched issues. Addressing them may require major reforms that move away from systems so heavily reliant on corporations trying to maximize profits from people's health needs. So I think in government yung kailangan mo act kay so that the insured Americans kanang mugamay na sa karon na year or on the next future years. Some possibilities could also include like expanding publicly funded insurance programs to cover more people affordably, stricter regulations on what insurers can and cannot do, which kanang ako dito kanang dili kay sila nasa naay SRP pa suggested because nakaraan kay sila wala pas or over charge sa kanang consumers, and also transitioning to a universal Medicare for all, like Medicare for all style system that provides equitable access as basic rights. Okay. It's better na ma-preserve nato ang atong human ay atong people or people in our states rather than ang ato ang interest lang. Making healthcare truly affordable and accessible for all may kanang grabe magdid og kailangan og kanang changes sa ato ang government o ang ato ang system natong andan. Maybe mo na kailangan buhaton, diba? Aron makuan pud ang widespread inequalities. So this ends my video report. And here is the references which you can click and visit and read it yourself. Kanang daghan siya og kanang graphs and daghan siya og graphs og kanang background na studies which kanang lingaw dili siya basahon. Although nadugay ko og kanang himo because ang video is one day heads up lang na buhaton ko. So nangit asad ko og kanang software na maka-record sa video together with the PowerPoint kay kanang sa Zoom is magbaylo-baylo ang PowerPoint ug akong gusto ko kanang na PowerPoint makakita ko ng istorya ko. Na wa ko nagbasa og kanang kini bakit nagkalistog English but I survived. So may we learn something and may we answer the research gap and may you have a fruitful finals of this sem. Thank you. Bye.